Hi, good afternoon, everybody. My name's Lynn Markey, and I'm the Director of the Coalition for Life Sciences, and I want to welcome you here today for today's presentation of the Congressional Biomedical Research Caucus. It's also our 25th anniversary of hosting these caucuses, and a large part of our success is in part to our co-chairs, and those are Representative Steve Stivers from Ohio, Representative Charlie Dent from Pennsylvania, Representative Jackie Spear from California, and Representative Rush Holt from New Jersey. It is due to their commitment that the caucus has been running for 25 years, and we are able to host these federally funded scientists from across the country and highlight the amazing cutting-edge research taking place here in Bethesda and across the country. So today is my great pleasure to introduce Dr. Anthony Fauci, the Director of the National Institutes for Allergies and Infectious Diseases at the National Institutes of Health. 25 years ago, during our first year of hosting briefings, we discussed the reality of an AIDS vaccine. That was in 1989, and contracting AIDS was still considered a death sentence. While science has still been unable to crack the biological code to create the vaccine to treat this disease, today it is considered more of a chronic condition if you have access to the available treatments available. And Dr. Fauci has been a leader and on the front end of driving research on HIV/AIDS. He has made seminal contributions to the understanding of how HIV destroys the body's defenses, leading to susceptibility to deadly infections. Further, he has been instrumental in developing highly effective strategies for the therapy of patients living with HIV/AIDS. He continues to devote much of his research time to identifying the nature of the mechanisms of HIV infection and the scope of the body's immune response to HIV. Dr. Fauci is the recipient of numerous prestigious awards, including the Presidential Medal of Freedom. He is a member of the National Academies of Science, the American Academy of Arts and Sciences, the Institute of Medicine, and the American Philosophical Society, as well as many other professional societies, too numerous to name. So with that, I would like you to join me in welcoming Dr. Anthony Fauci.
Thank you. Thank you very much, Lynn. It's a real pleasure to be here with you this afternoon to talk about this topic, which is, as Lynn said, we've been talking about it for a very long time. I've been involved in this, as some of you know, from the very first week that the MMWR came out in 1981. And this has been an extraordinary journey of challenges, frustrations, and a lot of accomplishments. And as you can see from my first slide, that's what I'm going to talk about today. I'm going to talk about what has been accomplished, but I'm also going to spend a considerable amount of my allotted time to talking about the challenges of things that we need to do. And I will leave some time for questions, and I'd be happy to have any discussion on any of the issues that are of interest to you. So first of all, let's take a look at the scope of the problem. This is something that sometimes we get a bit complacent because of successes in realizing how extraordinary this pandemic has been, with 70 million total cases, 36 million deaths, 35 million people living with HIV. And to answer the people who say it's over, take a look at the numbers in the last two bullets: 1.6 million deaths and 2.3 million new infections in 2012. I'm going to get back to this slide in a minute when I talk about some of the accomplishments. In the United States, again, a degree of complacency because we do have the capability to deliver effective care and therapy, which has transformed the lives of HIV-infected individuals. But again, the numbers are stunning: 1.1 million people living with HIV. Importantly, and I'll get back to it in a moment, about 16 to 18% of the people don't know they're infected. There have already been over 600,000 deaths. And the thing that's embarrassing and tragic for us here in this country, that there are still 50,000 new infections each year, and it has been that way for almost 2 decades right now. So we went up and we were dealing with 120, 130,000 new infections in the early years in the 80s. It came down precipitously, but it hasn't gone down below that level, which is really an unacceptably high level. We have disparities racially with men who have sex with men, particularly African Americans, who are disproportionately afflicted to the tune of about 50% of new infections, despite the fact that 12% of the population is African American. And then we have a problem with youth because there's a considerable number, almost 30% of the infections are among essentially children and adolescents, 13 years old to 24 years old. Now, getting to the much accomplished and extraordinary amount, again, the investment in biomedical research and in public health and in global programs like PEPFAR have been extraordinary. I could spend my entire time discussing each and every one of the issues on this slide, but the one that is indeed the most transforming is in the arena of treatment. For those of you who didn't know me when I was young, that's me in 1981, when I was taking, and still do, take care of patients up at the NIH Clinical Center. The reason I show this slide is not to show that I did and once have black hair, but to tell you that when I was taking care of patients then, the median survival without therapy was 6 to 8 months, which means that 50% of my patients would be dead in 6 to 8 months, and 100%, not 100%, but close to 100% would be dead within a few years. If you fast forward for the development of antiretroviral drugs, starting with the screening of AZT all the way on the left-hand side of the slide in 1987 and its approval, remember now, some of you may not realize that was a drug that was developed unsuccessfully for cancer that turned out to work against HIV. And then from then on, all the drugs were targeted for a particular component of the virus replication cycle, which was really based on a few years worth of fundamental basic science in delineating the replication cycle of HIV. So if you fast forward from my slide of 1981-82 to the present day, if that same person would come into my clinic just 5 miles north of here in Bethesda, same room, same place, we're still doing the same thing 30 plus years later, and came in and was a 25-year-old who was recently infected, and I put him on antiretroviral drug, which I can give him 3 drugs in 1 pill today, which we had 28 pills for a few drugs in previous days. I could look the person in the eye and tell them with a degree of honesty, total honesty, that it is highly likely that they will live an additional 50 years. And I got to really pause for that, because when one talks about the relationship between an investment in biomedical research and something that's tangible, you know, I've testified before Congress, I looked up in our records, you're not going to believe it, but it's true, over 200 times over the last 30 years. And the question I keep getting asked, what have you done with the money that we've given you? It's a reasonable question, and that's what we've done with the money that you've given to us. So it's really one of the more transforming advances in biomedical research. You superimpose upon that implementation programs, and the United States of America should be very proud of that, particularly in the form of the PEPFAR program, the President's Emergency Plan for AIDS Relief, which was initiated by President Bush in 2003 and continued by President Obama to the present time. The Global Fund, the World Bank, philanthropies like the Bill and Melinda Gates Foundation, and importantly and most recently, host countries actually assuming the responsibility for a disease in their country. Again, the results of this have been nothing short of spectacular. When I went to Africa at the time to put together the architecture for the PEPFAR program, when the president asked me to do that in 2002, there were less than 50,000 people who were receiving antiretroviral drugs. Now there are about 10 million people, which translates into about 4 million lives saved over the period from 2002 to 2012. There is a phrase, a concept that has been used over the past few years. Hillary Clinton spoke about it when she spoke about the AIDS-free generation possibilities, called the tipping point. And that means when the number of people going on therapy exceeds the number of people who are newly infected. So if you do the mathematical modeling of any epidemic, assuming correctly that putting someone on therapy will save their lives and prevent them from infecting somebody else, the trajectory of the pandemic starts to go down, and that's why it's called a tipping point. And right now, 13 low and middle income countries have actually reached the tipping point. And as more and more countries reach that tipping point, that's when you're going to start to see the mathematical model show the deflection as opposed to the inflection of the epidemic. So with those results there, Getting back to the depressing slide of the data of the epidemiology, there's been about a 30% decrease in deaths since 2005. I could spend the whole time in prevention. My message to you, a couple of take-home factoids, that prevention is not unidimensional with HIV. It's a multidimensional, heterogeneous combination of preventions. There isn't anything that absolutely works except abstinence, but there's no such a thing in my mind as abstinence out in the world that we live in when it comes to HIV, at least something that doesn't even approach statistical significance. So having said that, these are the combination preventions, and they've really been a wide range. When we first started doing this, before we even knew HIV was the cause of AIDS, it was condom because of the suspicion correctly that it's a sexually transmitted disease, needle exchange, behavioral modification. Then we got into the medical interventions, like treating mothers to prevent infection in the babies, to give pre-exposure prophylaxis, topical microbicides, circumcision, and the very important treatment as prevention, which sounds somewhat oxymoronic, treatment as prevention, but it really isn't, because we know now from NIH-sponsored studies that if you treat someone who's HIV infected and bring down the viral load to below detectable level, you make it not impossible, but extremely, extremely difficult for that person to infect somebody else because the viral load. So you get a twofer when you seek out, test, treat. You save someone's life and you prevent them from infecting somebody else. And that's what combination prevention has done, and the results shown on this slide, that again, over a period of time shown on the slide from 2001, there have been about a 33% decrease in new infections. So that's much accomplished. I want to spend the majority of my half an hour time, like I said, I'm going to leave considerable time for questions, on the challenges of much to do. So I've broken it down to go into little blocks because each of them are a little bit different and require a different approach. So if you look at the landscape of what the challenges are, starting off with implementing what we already have. So I like to think of, if we didn't do anything new with no new innovations, and we just implemented what we've already have, we could do a lot better than what we're doing. Then if you superimpose new discovery of new things, and they're obvious, I'll get to them in a minute, a cure, a vaccine, better drugs, then you add on to the issue of implementing. But right now, let's take a look at implementing proven interventions. First, in the arena of treatment and care, and I have on the right-hand side of the slide 3 selected priorities, and let's take a look at some of them. And many of them are based on what I just showed you or spoke to you about a moment ago, that when you treat people, you save their lives and you prevent them from infecting others. So let's take a look at where we need to do better. And that is to make antiretroviral therapy, which is shown on this slide as ART, A-R-T, make it universally available to those who actually need it. And the WHO and the United States Public Health Service recommendations essentially say that you give it to people much, much earlier in the course of their infection. Years ago, in this room, when I was discussing things when these drugs first came out, when do you start therapy? And there was a debate that maybe the toxicity of therapy over a lifetime would actually diminish the total effectiveness because the toxicity might outweigh the benefits. We know now for absolutely certain that it is worse to have a virus replicating than it is to take any of the approved drugs. For absolutely sure, no debate, case closed, and there are a number of very good studies that have shown that. So the recommendations now, it used to be when the CD4 count goes below 200. Now, less than 500, but you could even give it if it's more than 500, provided you explain and have a dialogue with the patient that they may, be starting to not feel so well, because when somebody's CD4 counts over 500, the chances are they're feeling pretty well. And there isn't a medication that you can take that you don't know you're on the medication. Maybe an aspirin, but most medications, when you're on them, you know they're on them. So you got to convince them to save their lives, even though they're going from completely asymptomatic. But there are other things on here that are important. Children less than 5 years old, definitely. All pregnant women, you don't argue, is the woman who's pregnant, is she far advanced enough to start therapy? If you're pregnant, you go on therapy, and you go on therapy for life. If you're in a developing country, it's certainly after A, because you might get pregnant again, and B, it's likely that you have to breastfeed. Anybody who has comorbidities with tuberculosis or serious hepatitis B, and anybody who's in a discordant relationship, namely if your partner's infected. So we're getting really liberal now about saying when you should start therapy. Having said that, still now, if you look at the number of people who are actually infected and eligible for therapy, given the recommendations that I just mentioned to you, in the blue are those who are on therapy, and in the red are those who should be on therapy. So we still have to seek out, test, get into care, and put people on therapy. Let's go to the second one, close the gap in the care continuum. I know some people in this room understand what the care continuum is. The care continuum is from the time that you are infected until you get into care, stay in care, get in treatment, stay in treatment, bring your viral load to below detectable level. So there's a big spectrum. The problem is that we have gaps at every level. And let me just go through this slide with you because it's a very important slide, and to me, really a depressing slide as a citizen of the United States of America, or a citizen of any part of the world, because it's not any better in other places. But in some places it is, which is to our embarrassment. 1.1 million people living with HIV in this country. 18% of them don't know they're infected. Before we go any further, 50% of all new infections come from someone who does not know that he or she is infected. So pause for a moment and do the math. If you were accessing everybody who didn't know they were infected and put them on therapy, tomorrow you could decrease by 50% the new infections in this country. That is a healthcare delivery problem. That is not a problem of whether a drug works. So then go down and take a look at the number of people who are in care, 60+%. The number who stay in care, much less. The number who go on treatment, less. And then when you finally get to the reverse pyramid tip, 25% of the people in this country who are infected have a therapy which is bringing their viral load to below detectable level, which will A, save their life and prevent them from infecting others. Is that embarrassing, or is that embarrassing in this country? 25% of the people. So we got to do a few things. Besides healthcare delivery, which the Affordable Care Act will actually help getting people into therapy and getting their therapy paid for, but it has a lot to do with biomedical interventions and its interrelationship with human behavior. We need to understand and modify human behavior, and it's not easy because there are a lot of obstacles in the way of that. So let's go to the third one, to prevent and manage comorbidities. There's good news and bad news. The good news is that people are living much longer now, so that we are starting to see comorbidities that we didn't see before because the patients wound up dying. Now we see that there are a number of things that we must address because we have HIV under such great control. Two of the most important co-infections are tuberculosis and hepatitis B and C, but there are also chronic conditions, more cancers, not only AIDS-defining cancers, but any cancers, cardiovascular disease, renal disease, liver disease, neurocognitive impairment, and a variety of others. All of these need to be addressed. We've made phenomenal advances in the field of hepatitis C therapy, a total spin-off from targeted drug development that was initiated with HIV. So people, again, I get back to my testifying before Congress, the next question is when we put money in HIV/AIDS, does it help any other discipline? And the answer is overwhelmingly yes. because now in a totally different field, using targeted drug development, we've taken a disease in which there was a 48-week therapy that cured as few as 40% of people, that was very toxic, that is now 12 weeks and maybe 6 weeks of therapy, that's 96% curative with very little toxicity. Again, something that escapes public recognition, but it's quite true. So let's run over to prevention now. We'll go quickly through this. Again, there are 5 priorities that I've selected to very briefly discuss to you, and one is elimination of mother-to-child transmission. If you get a mother on therapy, get her viral load to below detectable level. You know, you never say never and you never say always in biology, but it's almost impossible to transmit to the baby if the mother's viral load is below detectable level. Not impossible, but almost. You're more likely to get hit by a car if you were walking across the street. So let's take a look at that. What has PEPFAR done? PEPFAR has now saved 1 million babies who would have been born infected if their mother had not been on antiretroviral therapy. In the United States, it's a very rare event that a baby's infected. Very, very rare event. Even in this city, which has the highest prevalence of HIV, we haven't had an infected baby born in this city in a few years. That's the good news. The sobering news is that despite the fact that we've saved all those babies, in 2012, there were still 260,000 infants who were born infected from an infected mother. It can go to 0. That's part of the goal, go to 0.
That's true in the United States.
What? No, in the United States, nothing. Practically nothing.
That's all in.
It's global. No, in the United States, like I said, it's very rare, just less than 100 a year, probably closer to 50. Mostly because we get prenatal care and people go on therapy. Sorry, I should have made that clear. Okay, the other one is to scale up medical male circumcision. And I hope we have some questions about that, but let me just assuming that if you circumcise a male medically supervised, that you could decrease dramatically the chances that they're going to acquire HIV infection. In fact, it's one of the most effective prevention modalities. We did studies in Kenya, Uganda, and South Africa years ago, and the results were 55 to 60%. Now, 5 years out in Uganda, we did a follow-up study, and it turned out it was 70+% effective in preventing acquisition. Now, I can assure you that if I had a vaccine that was 73% effective, you would see me on CNN in the Rose Garden announcing it with the president. That would be, I'm not being facetious, because that's very, very high efficacy, 70+%. And yet, if you look at the willingness or even the capability of getting people circumcised, we did a study in Rakai, Uganda, and that the coverage and the attitude towards circumcision was not optimal. Only 27% of the people surveyed were willing to actually adopt medical male circumcision. What about improved adherence to PrEP? PrEP stands for pre-exposure prophylaxis. Another example of it works, but it only works if you do it. Let me show you. This is a complicated slide, but what it shows, if you look at the top one right here, is that we did a study of 1 pill a day, every day, in men who have sex with men to prevent them from getting infected, despite the fact that they use condoms, supposedly, that they were careful, supposedly, but human nature tells you that even with that, people don't do it. However, it was only 44% effective. It was an interesting thing about the study, because if you said, I don't believe you that you're taking your medicine, but tell me, did you take it? And they say, no, I didn't, or yes, I did. If you count only the yeses, all of a sudden it becomes 70% effective. If you say, I don't even believe what you're telling me, I'm going to draw your blood and find out if you have a blood level. When you only count the people who had blood level of the drug, it was 93% effective. And there was a recent study showing that when everyone takes it, it's like 100% effective. So why, in so many studies, it is down to no effectiveness, 15, 39, Not very good. Again, it's a question of getting people to do what we know works. And one of the things that we've tried to do now with a recent study published is a long-acting antiretroviral drug, assuming that if somebody gets an injection 2 or 3 times a year, that would be easier to do than taking a pill every single day, because people don't like to take pills. They just don't. It's amazing. You say, but it's going to save their lives. People still don't take pills. Welcome to the world of human nature. Okay, how about pursuing treatment as prevention? I already mentioned that. It works. This is the original study that was done a few years ago. What we did is that we had people who were in this study, a discordant couple. One has HIV, the other one doesn't. You treat the person with HIV early in the course of their infection, and you compare it to a similar group where you just delay a bit. There was a 96% decrease in HIV transmission among those who started therapy earlier. Now, when you go into the real world of the trenches, there were 2 studies, one in KwaZulu-Natal in South Africa and one in British Columbia. And if you look at covering people with treatment and then looking at the incidence of acquisition in the community, it's very clear. In KwaZulu-Natal, if you increase treatment to 30–40% of the people as opposed to 10%, you decreased almost by 40% the acquisition of infection. The same thing in British Columbia. If you brought it up from 11 to 57%, you decreased incidence of infection by 42%. So what am I saying? Drilling it home to you. Treatment as prevention works. We're doing a study now to really nail it down because we really have to convince people about this. It's a study which is the population, it's called POPART, kind of a funny name, but it means population effect of universal testing and immediate ART therapy. And we're looking at 1.2 million people in a community in South Africa and in Zambia. And it was launched last fall. And what we're looking at now, if we intensively seek out, test, and treat, will be decrease the incidence. And I can tell you, the study's costing a lot of money. I already know what the answer to the study is, so why did the study? But I'm only kidding, I'm only kidding. All right. Okay, prevention. Targeted hot zones. What do we mean by targeting hot zones? What we're learning now is that HIV, now, years ago, in order to be, I think, naively politically correct, we used to say that HIV is an equal opportunity infection. Don't even believe it for a second. It's not an equal opportunity. It's very disparate. It's disparate in location. It's disparate by race. It's disparate by age. So it isn't a uniformly distributed. So having said that, there was a proposal made by a group of people, including Peter Piot and Mark Dybel and others who are actively involved in this, saying that if you concentrate your prevention efforts in areas that have high incidence, you would get more bang for the buck. That doesn't mean you forget about people who are not in high incidence, but you put most of your resources. So this is a map of the United States by county and shows HIV diagnosis. In any map in health, you probably already figured this out, dark is bad and light is good. Okay, so look at the dark zones of where the Southern California, Los Angeles, San Francisco, Miami, Newark, New York, Washington, D.C., etc. And it's like that throughout the world. You can go to individual regions, and that's where we're going to go in the future. So quickly, let me just jump over to new discovery very quickly. New interventions. First, a cure. Now, a cure is really confusing to people. Definition of a cure is that a person remains in a permanent remission after you withdraw therapy. We know a lot about cure. You come in with pneumonia, your doctor gives you penicillin. 2 weeks later, you're cured. Penicillin stops, you're good to go. You have a cancer, does a surgery, a little chemotherapy. 10 years later, you don't have the cancer, you're cured. It's tough when you talk about cure with HIV because we don't have enough experience to know what cure means because the virus hides in places in the body, some of which you can't access, like the brain and other areas. But when you look at cure, you got to look at 2 major buckets. And again, it's not that simple, but I'm going to try and make it simple. One is virus eradication. Get rid of the virus. It's going to be really tough to do that because HIV, like no other virus you've ever heard of, integrates itself into the genome of your cell. And even though the antiretroviral drug suppresses it very effectively, you look well, you feel well, you're as good as you can be, you still have the virus in you. So that when you stop therapy, the virus comes back. If you eradicate it, that means there's no virus there. We've not eradicated it really, except maybe in one person in a really unusual situation. So then there is the Mississippi baby that was now become a very famous baby, in which you know the story. Baby was born of an infected mother in Mississippi, no antenatal care. The physicians, instead of assuming that the baby was not infected and treating the baby with a lower dose of fewer drugs, until 3 weeks later, they proved the baby was infected. They say, this baby is at such high risk, I'm going to treat the baby now, immediately after birth, within a few hours, 30 hours, as if the baby was infected. And as it turned out, the baby was infected. Then the mother put the baby on therapy for many months, went away, lost the follow-up, and stopped therapy. The physicians didn't say stop, the mother stopped therapy. And as it turned out, when they came back to clinic, they couldn't find virus. So that was sort of an accidental cure, which means that if you treat early enough, you may not allow the virus to establish itself in a way that's now so recalcitrant. Remember now, folks, that's good for babies. 99.9% of the people who are infected as adults, including the several thousand that I've taken care of, you don't know they're infected until months, sometimes years, until after they're infected. Of all the patients that I've seen, I may have taken care of 20, 30 patients who were infected within a week of the time that they came to me. Most of the time, it's later on. But to answer the question, does early treatment in a baby possibly cure a baby? We're doing a study now in which we're going to randomize into groups of a mother who has no treatment and treating the baby within 48 hours immediately, and then taking the baby off therapy after a couple of years. Because the risk of treating an uninfected baby was very huge in people's mind, because we never knew we could cure a baby. Now that it might be possible to cure a baby, the risk-benefit ratio swings way over to taking the risk of treating the baby as if the baby was infected, even before you know the baby is infected. Okay, then there's the real draconian things. The Berlin patient who had a stem cell transplant from a donor who had a genetic defect in which the virus could not infect it. That's really great for the newspapers. It's almost meaningless to the 70 million people who are infected and the 36 million people who are infected, except that it gives you a clue that if you could do something about that receptor, and people are starting to use gene therapy now, particularly a group in Pennsylvania, at the University of Pennsylvania in Philadelphia, in which they're taking blood from an individual and trying to suppress that receptor that the virus binds to and give the blood back. Has not been thoroughly successful yet, but it shows you one of the things you can try to do that would be much more applicable than doing a stem cell transplant on anybody. Okay, now the one that I think is the most feasible to do, I can tell you right now, I don't think we're going to be curing everybody who has HIV infection. You heard it right here in the Rayburn building. I don't think that that's going to happen. I think there will be some people who, if they're treated early enough in their infection and you preserve their immune system and you have a very small reservoir, that you might be able to withdraw a drug in them. And that's the reason why there's a link, strong link in my mind, between the care continuum and whether you're going to cure somebody. Because you're not going to cure somebody if they come into your office 3, 4, 5 years after they've been infected. Again, you never say never and you never say always. Really unusual in my mind. So now there are a number of individuals, particularly a cohort in France, another cohort in Thailand. We have people we're doing in the United States now, where when they come in, they get treated really very early. And the French cohort, referred to as Visconti, is a cohort in which individuals actually were treated very early in the course of their infection, and then they were discontinued therapy, and a certain segment of them, certainly not all of them, they never rebounded, which means that the early treatment had such a small reservoir. We know the virus is still in them because when you take their cells and you do molecular probing, you could find the virus, but the virus doesn't rebound, and we don't know why. We don't know why because it's in a cell from which it doesn't rebound, whether their immune system is suppressing it. But the good news is at least some of them are not. You know, the president has pledged $100 million to find an HIV cure, so cure is really very much on the forefront of our minds. But I want to leave cure, and then I'm going to finish up with vaccines and open it for questions, to make sure you understand. When you read in the papers about these amazing things that are done to a single patient, in my mind and in the mind of many of my colleagues, if a cure is going to be worthwhile, it's got to be simple, it's got to be safe, and it's got to be scalable. You can't have something when you have 36 million people infected that costs $10 million to do and puts the patient more at risk than the one pill you'll be giving them that they have to take every day. I'd rather take one pill a day than put myself at risk of a procedure that's going to kill me. Okay, and finally, vaccines. That's the holy grail of HIV research right now. So, who did the first vaccine trial in the United States? You don't know. The National Institutes of Health, who your members fund all the time. Yes, 26 years ago it was done, and it was a failure. So that's the good news, we did it. The bad news, it was a failure. But it was a failure because we were rather naive in thinking that you could treat it like any other vaccine, get the protein, inject it into somebody, and boom, they'll make a neutralizing antibody, and just the way we do it every other vaccine. What it did in a journey that has now been more than 25 years taught us is that unlike any other virus that we've ever dealt with, the body does not make an adequate immune response to HIV. So when I was in medical school, my mentors used to tell me, if you want to make a vaccine, mimic natural infection, because natural infection, after it's over, leaves the person clearing the virus and essentially immune to reinfection. The problem with HIV is that no one ever spontaneously clears HIV, so the immune system is inadequate. Having said that, a few years ago, empirically we showed in a study that was done in collaboration with the Thai government and the United States Army that if you vaccinated people with a certain candidate, you had a modest efficacy, 31%. Not good enough for prime time, but at least proved the concept that you can protect. And studies over the next several years have pinpointed it. It really is a humbling experience because everybody, all the smart people in vaccinology and immunology were saying, well, you got to make an antibody that's a neutralizing antibody against a very constant region of the envelope. And it turns out that this 31% efficacy had nothing to do with CD8 cells, which were supposed to be important, was not neutralizing antibody, and was against the variable region. So that means we still have a lot to learn. But the holy grail is still going to be neutralizing antibody. And we know now, this is a complicated slide, I apologize for it, but what it really tells us is that there are 5 spots. This is the envelope. So this is the virus. I've blown it up to show this little piece is now blown up. There are multiple components with names that you don't need to ever remember, for goodness sakes. But it shows you that there are 5 different components that are the targets of neutralizing antibody. So we know that rare people make antibodies against these. That's a great clue, because now what we're doing is we're going to try and take these things here, which are called epitopes, and we're going to try and make them immunogens so that when you inject them into people, they'll start making the neutralizing antibodies that we know the body will make. When that happens and we get a vaccine, then I think we're going to really be able to talk about that deflection, because I've been talking about this, that scaling up our programs and the deflection, and I think when we get a vaccine, and I think we will, I don't know when, you can't predict with discovery, that we're going to see a major deflection. And when we get there, then I think we could feasibly talk about an AIDS-free generation. So why don't I stop there, and I'd be happy to answer any questions. Thank you. Yeah.
I have a question about HIV and mutations. How susceptible, and can you say a little bit about mutations in HIV? Is that something that concerns you? And
Sure. Well, HIV is an RNA virus, and like other RNA viruses, it is probably the king or the queen of the mutational RNA virus. RNA viruses mutate a lot because they don't have good proofreading mechanisms. When a virus or any gene replicates itself, it makes a copy of itself. RNA viruses make a lot of mistakes in the genetic code, so they mutate a lot. Mutations, many of which are irrelevant. The important mutations in HIV are that, one, it evades the immune system. It's one of the 3 or 4 reasons why the immune system is not particularly effective, so it's not good for the natural immune response. It's also not good when you treat someone with an antiretroviral drug and you don't treat them effectively. The selection process selects for the mutants that are resistant to the drugs. And finally, because it changes so rapidly, that it also makes getting a vaccine very difficult. So the answer to your question, which is a great question, is that mutation is a critical issue with HIV. It's a critical issue with any microbe, but HIV mutates much, much more than most microbes. Yeah.
Are there lessons from PEPFAR that we can apply to domestic programs?
Yeah.
As far as adherence goes?
Well, maybe not adherence, but there are some lessons for adherence, but let me answer your question about PEPFAR. PEPFAR is an amazing program because it showed that when you pour resources in a way that's accountable, and that was one of the things that President Bush insisted on. He wouldn't just dump money into a country, but it had to be to an organization that was accountable. You can do amazing things. I mean, to say there was a lot of debate when we were putting the program together that you'll never be able to have people in the developing world come into a clinic, get tested, get on care, and take their medicines every day. And they were absolutely incorrect, because if done properly, you can get people. So a lot of people are saying, and I think it's appropriate, that we almost need to have a mini PEPFAR in our own country, in the sense of really aggressively seeking out testing, getting to care, and getting everybody who needs to be on therapy, on therapy. So that's the big lesson. It can be done, even though it seems absolutely impossible given the circumstances. Yes?
Kind of follow up on the first question. About a month ago, we had a very scary brief about drug-resistant microbes and the crisis in the world related to that, so forth. And of course, the message was that no matter what we do in advancing agents to fight bacterial diseases, nature always lets one survive, and so you got to be ready to deal with that one. But also, we were talking about process, and talking about the reciprocal is that the Black Plague killed almost everybody, but there were a bunch of people that survived the Black Plague. And so from a process standpoint, what we got into was we need to understand better, talking about the few humans that survived the Black Plague, how is it that our species hasn't been wiped out by this stuff? So my question is, when you were talking in your last slides about cure, is one of the things that you and your colleagues need are just better tools to understand how the immune system might be able, with the 1 in 100 person, be able to survive this thing, and how can we duplicate that natural process?
Yeah. Okay, so I hope you're not saying that we should let natural selection kill people. I'm only kidding. I'm just, you know, there is a group of individuals called elite controllers, less than 1% of individuals, who likely, because there's something special about their immune response that allows them to not eliminate the virus, but to actually survive without the virus replicating. Okay. They're not cured. They're not cured. No one has ever been cured, period, spontaneously. But that group is a good group to study, to try and get your arms around what is the nature of the immune response and try and replicate that. The only trouble is, and it's a little complicated,
is that they are heavily weighted towards a certain genetic genotype, namely an HLA-B5701 and HLA-B27, which means that they may require that particular genomic background to do it, and you can't be changing genomic backgrounds in people. But your question about learning from people who do well is a very valid question, and that's one of the examples. Right. Yes?
In thinking about the potential for an HIV vaccine, what lessons do you think the HIV community would take from the rollout of the HPV vaccine and the problems that they saw with promoting a vaccine against sexual transmitted?
Yeah. When we get, and I say when with a degree of optimism, when we get an HIV vaccine, it is extremely unlikely that is going to be implemented as a broad vaccine for everyone. One of the problems that we face with HPV is that it is the only way that you're going to have an effect of the vaccine is to essentially vaccinate all women of a certain age before they have their first sexual contact, or hopefully before. And now, obviously, pushing to have men, young boys, also vaccinated. Because the nature of HPV and its relationship to both cervical cancer, anal cancer, penile cancer, oropharyngeal cancer, really relates to what is considered almost normal behavior. In the sense of just normal sexual interaction that you're going to have as you mature and become an adult. That is different because HIV is not a homogeneously spread risk in the community. And when you're thinking about vaccination for HIV, it'll very likely be those people who are at a well-known risk. Whereas HPV, if you have sex, you are at risk, period. Whereas with HIV, yes, you're at risk if you have sex, but if you're a gay man having frequent anonymous sex, if you're an injection drug user, commercial sex worker, etc., or if you're in a relationship with someone who actually is HIV infected and is in a discordant, that's the high risk. So your question is, we have a great vaccine, I think, we have a great vaccine with HPV, and yet people are not using it, right? How do you learn a lesson from that? And you emphasize the risk that someone might have, and that is a much greater incentive to get vaccinated. Yes?
If I could ask one more little bit hard. Your community came together a couple of decades ago to attack the end of the world that the Ebola virus was going to create.
You like that end of the world stuff, don't you?
Well, because this history was all about there's always one
Right,
that survives.
right, okay.
You know, how do we learn how to
Right.
deal with that? So my question in this case is the international community really working at this across the board, or is it really just the United States and a few of our best friends that are trying to deal with this problem?
Well,
Come up with
okay, so let me, if I might, with all due respect, Ebola will never, ever wipe out the world, ever. Because Ebola is a very unusual infection that you don't get it unless you're in really, really, really close contact with a very, very sick person. But let me answer the second part of your question. Yeah, it varies depending upon the country's resources and interests. Obviously, the United States is a very rich country. We're very attuned to both domestic health and global health. We've had a major investment in global health for a very long period of time, and I think a wise investment. There are other countries, many European countries, Australia, Canada, that feel the same way as us. But I think because of the fact that we're disproportionately wealthy and we're disproportionately put resources into health, including global health, that we're the main player in this field. Yeah. Okay, oh yes?
What's the timetable for finding a patient who is infected to treating retroviral therapies and then to viral loads or undetectable?
Okay, there's good data on the third part of your question, but the timetable is that if someone is exposed and they say, I really think I got exposed last night, within a few days to a week, even before they convert their antibody test, you could do a very sensitive assay for virus and know they're infected, okay? As soon as you know someone's infected acutely, you should treat them immediately. And then you ask the question from the time that they come in to the time the virus goes below detectable level. If you treat them early enough, their virus never really goes way up. But let's assume someone comes into my office and says, I'm infected, I think, and you take their blood and A, they are infected, and B, they have a viral load of 500,000 copies, which is pretty high. If you start them on therapy, within a period of about 2 weeks, you'll start to see the virus going down. Within a period of 4 weeks, it'll be very low, and by 6 weeks, it should be down. Yeah, so it's about a month and a half. Yeah. If you go for 2 to 3 months and it hasn't come down, then you better take a look at the drugs and make sure you're not dealing with a resistant microbe. Yes?
Question about, so we've done a great job about protecting the blood supply in this country,
Right.
but blood donation policy is still, you know, an issue as far as the deferral criteria for otherwise healthy men who have sex with men and who are not practicing risky behaviors, and they are being excluded from
Right.
it. Is there any evolution going on?
Yeah, that question keeps coming up. Unfortunately, it hasn't changed yet, but I think it's ultimately going to change. The question is still alive and asking. You know, before there was absolute exclusion, now it's being a little bit more liberal in it. But I think it's going to keep, it's an iterative process. It'll keep coming up. Yes?
We spend a lot of time in this room hearing from people like you. What do you need from us to help you do what it is you need to do? Besides money.
You know, besides money, there's two types of legislation, as you know. There's authorization, which often puts into bills things that don't help you very much. And then there's appropriation, which if it's right, it always helps you. So let's stick with appropriations and just tell you a fact that you know. The NIH budget doubled from 1998 to 2003. If you look at the history of the NIH budget, it goes blips like this, but over a broad 30, 40-year period, it generally doubles every 10 years. But from 1998 to 2003, due to a lot of enthusiasm on the part of people in Congress, Al Inspector, Tom Harkin, John Porter, and others, it doubled. That's the good news. From 2003 to today, it has now never, ever gone to meet inflation. So the budget's been flat. Inflation's about 2 to 2.4% biomedical, because biomedical research inflation is always a bit more than standard public inflation. So we lose about 2 to 2.5% per year for the last 11 years. So the NIH's purchasing power has decreased by 25% over the last 10 years. Superimpose upon that the sequestration, which, as you know, is $1.5 billion, and then generously 1/3, 2/3 of it was given us back, $1 billion, with the omnibus of 2014, of which $500 million was immediately tapped out for the Affordable Care Act. And now the 2015 budget is a 0.7% increase with a 2.5% inflation. Sorry to stick with money, but you can't do the things that we've been doing over the last several years if you lose 25% of your purchasing power in 10 years. That's just a fact. I mean,
With the infusion of the ARA in 2009.
yeah, but that was 1 year money. Yeah. So, I mean, again, I know it sounds almost like you're whining, but it isn't. I mean, it's really a fact that biomedical research, we are the leaders in the world. We've been the leaders in the world. We're losing it now, for sure. People don't want to go into biomedical research. People are actually doing the unthinkable. When I was a young fellow, the thought of leaving a United States lab to go to China or Singapore or India because the resources are better there, that was like laughable then. Now, you know, 18, 20% of people are thinking of doing that. Yeah, yeah. It's really not good. Anyway, sorry, but that's the fact. Okay, thank you.